Experimental design is effectively inseparable from statistics when you are talking about most areas of health science literature. But experimental design includes a few more things too. So it's important to get the stats right, of course, but we want to talk about the others as well. Our first step should be to think about what question or problem we are trying to answer. Usually you want this to be relatively specific, since you'll be designing an experiment from it. Before we get started with talking about this together, take a moment and pause and think about why it might be particularly problematic to simply collect a lot of data on a topic and then analyze it. If you need a second, go ahead and pause now and come back when you're ready. So hopefully you thought back to our last lecture and saw that this is a place where p-hacking can occur because you are giving so many degrees of freedom. There are times when doing this is quite reasonable and p-hacking just isn't a part of the equation because it doesn't rely on statistics. For example, if you are characterizing a particular molecule or molecular pathway, or for making a library of chemical compounds to run to find a possible drug target, or altering, basically at random, genes in a species to see what effect it might have on their phenotype. These are cases where, although not at all specific, it's still completely reasonable to have a pretty wide open question since there isn't really a possibility for p-hacking. The next two things to consider when we're talking about medical experimentation is the who. What population? And this can be trickier than it sounds, and I'd argue that some of the ways that we do it probably aren't particularly ideal. Ideally, you'd find a representative sample of the people that you want to treat or learn about. So if you're interested in learning about heart disease, you'd want to get a representative sample of all age groups likely to be affected by heart disease. If you want to see the effects of a drug or other treatment, you'd want to get a representative sample of all people who may use the drug. That being said, the more variable your population, the harder it is to show, well, most things. Most often, drugs work best when given at a particular phase of the disease, but if you want to test it for any time point, that could be averaged in, or you need to have enough people taking it at each to have the power to show that. And these trials are very expensive, so adding more people is very expensive. Another very common issue is the desire to test drugs in patient groups with a low number of comorbidities. While this can make for a far cleaner study about specifically the issue of interest, it may not be the most clinically relevant if the condition you're treating tends to be in populations with a lot of comorbidities. And even more dangerous, it could miss important interactions with those comorbidities. Pause this video and go read this article. It's not particularly long, but it's very important. Spend a few minutes thinking or discussing the following questions. For the sake of continuity, I'm going to go ahead and discuss them here as well, rather than trying to separate it out into another video. But please take some time, even if you do listen to my discussion, to discuss it with each other. Go ahead and pause here and come back when you've read it. This is quite a big problem in medicine. They are working to fix it. As you can see, this article is starting to get a bit old. But given the time and the cost of trials, it is far from fixed. It's an interesting issue when you try to think about why. Because on one hand, you have researchers saying, okay, the genders will likely react the same. And yet, they are in many cases specifically excluding women because their complexities could mean that they don't react the same, which seems to directly contradict each other. As with most things, it's probably some complex interplay of all the reasons you suggested, which generally includes mainly male researchers, female systems actually being more complex, a lack of really caring about women's health, and in many cases men having higher rates of the things that they are studying, and various other societal issues. And this is definitely a big problem, as we are finding out more and more things do react differently in female bodies and systems than in males. Sometimes dangerously different and requiring completely pulling the drugs. This is definitely one where brainstorming the fixes is easy as compared to implementing the ideas, largely because of the expense. It requires some sort of regulatory issue as a general rule because the cost is so expensive. Moving forward, we can simply require that before a drug comes to market, so long as it's applicable, it's tested on both males and females. For the drugs already on the market, it's a bit trickier. There isn't a lot of incentives to do those studies, so they'd either need to be required or funded. Especially for those already in the generic, that's going to be a tough issue to regulate as no one really has the incentives to pay for the studies, so likely funding would need to be provided. There are usually other great ideas put forth by the groups, and these certainly aren't the only ones, so discuss with your group and we can discuss them as a class as well if you like. We have a lot of variables to deal with in experimental design as well, and there are many ways of dealing with these. Generally, the goal is to change one variable and see the change in another. If we're doing a drug trial, for instance, we would want to give the drug and see the effect. However, we have to deal with a lot of issues. For instance, the placebo effect, where knowing you're taking a drug makes you get better even if the drug itself has no effect. This is where we bring in control groups to try and provide a way of eliminating as many confounding variables as possible. We can account for all of these confounding variables statistically, but that can be really tricky. One of the better ways of doing this is through what we call matched pairs, though this of course can be matched trios or more if you have a variety of different experimental groups, such as different dosing groups. In this case, you try to match people as closely as possible in pairs or more, and then randomize within the pair rather than the entire group. This is a way of making your control group and your experimental group as similar to each other as possible while still providing randomization. There are also lots of ways of controlling variables that we won't go too far into, but they need to be controlled for somehow, or if they cannot be, then they should at least be addressed in the statistics. This comic is talking about a study where they linked meditating with many things. But everyone in the study were highly practiced meditators, so there is an argument that the average person trying to meditate wouldn't necessarily get that benefit. And that's a pretty important difference. Maybe you're willing to devote an hour spread out over a week to something that will work now, but not if it's going to take 10,000 hours to get to the point of working. We want to be careful about overusing this argument, as we can always give reasons for why we are the special exception to the rule, but really big differences like this definitely should draw a question mark about whether it's applicable to the other groups. After we talk about our variables, we need to set up a treatment and design a structure. I already talked a bit about matched pairs, and there were other options in your reading, so I won't go too far into those, and will refer you to those. We also need to decide how the replication should be completed. Should all patients go through the system at once? Should the data be analyzed throughout to decide if the experiment needs to be stopped due to safety? How will that be done in a way that doesn't compromise research blindedness? Ideally, you want as much replication as possible. However, this can get very expensive very quickly, and that cost has to be figured into the experimental design. Remember, no science is perfect, and budgetary considerations is one place that perfect versus possible has to be figured in. And just because something isn't perfect doesn't mean that we can't get really good information from it. Variables definitely come into play when we're talking about treatment structure, beyond just the dependent and the independent ones. We need to remember to consider our groups into the structure, and we need to have enough people in each group that we are interested in looking at. What this looks like is going to vary tremendously from experiment to experiment. These are some of the typical demographic variables that we might look at, but there of course can be a lot more as well, depending on your particular experiment. Ordering effects come into play when one part of the experiment affects another in an unintended way. A fairly standard example of this might be if you're having Alzheimer's patients do particular tasks. It could be that one of the tasks actually helps teach them how to do a different task, and the order of the tasks are done in makes a difference on their performance. Selection effects occur in situations where you are unable to truly select a random sample. A great example of this is most psychological research is done on adults ages 18 to 22. Since most psych research happens on college campuses, and that is where they recruit from. Another example is in polling. If CNN and Fox both ask their viewers to send in their votes by text votes for a poll, you're going to get tremendously different selection biases. And also, we'll have another additional selection bias, not just based on CNN versus Fox, but by only getting those who can text. Spend some time talking with your groups on ways that you think that you can mitigate the effects of ordering and selection bias. Feel free to go out and do some research on this if you need to be able to answer them. Experimenter bias is basically exactly what it sounds like. This is the reason why you'll hear the phrase double-blinded trials so often. You want to make it so that while the data is being analyzed, the experimenter can't subconsciously direct the results. It's important to note that this is a way around subconscious bias affecting the results, not a way to stop fraud. Think of a true believer using a Ouija board. They aren't trying to lie, but their subconscious movements can get a particular result from the board. Making sure that the experimenter can't accidentally do this is tremendously helpful in getting high-quality analysis. There's also versions of this that can be done with experiments in other fields that don't use groups of people or animals to effectively hide their data from themselves. So only after they have done the analysis and committed to an answer about, for instance, where a particular peak lies, will they know if their answer was expected or not. People are generally pretty familiar with the idea of the placebo effect, but check out your handouts if you need a refresher. In your groups, talk about why you think this might occur and why we need to account for it. Also, keep in mind that you can literally hand somebody a bottle of pills labeled placebo, explain to them what a placebo is, and there is still a measurable placebo effect. It's honestly pretty amazing. It's incredibly important when designing experiments to make sure that the experimental tasks are valid. Obviously, this comic is a bit of a silly example here, with an octopus versus a cat, but it does make a point. This comes up more frequently in social science and animal tasks, but there are certainly medical places it can come up with as well. One I can certainly think of is brain training games and their relationship to Alzheimer's or other forms of dementia. Does the task you are measuring actually relate to the patient's real-life experience? Think by yourself or in your groups about other places that this could come up in general or specifically in the medical literature. Though certainly not medical literature, this is one of my absolute favorite examples of the issues talked about in the previous slide. A classic test that people have used to show how smart crows are is shown here. It should be noted that this setup is designed to be unbreakable. The idea being that the animals will use rocks to raise the water in the tube until they can reach the floating treat on top. In this case, marshmallows. Generally, both sinking balls and floating balls are given to the animals so that they have to determine which one to use. The raccoons, when given this test, did not, let's call it pass, in the way that the test was intended to be passed. They did not throw the rocks to raise the water level. However, by the definition of get the marshmallow, they definitely passed. For example, in one case, they broke the unbreakable system. When given floating balls, they bounced them into the water to get the marshmallows to stick to the ball or to the walls where they could then reach them. This included spinning the balls to get more stickage. So the question in something like this becomes, then, did they pass or not? Which is where this quote comes in. It is important to remember that there are times when a double-blind, randomized, placebo-controlled study absolutely cannot be done. And this doesn't mean that we cannot know anything. For example, it is completely unethical to give very sick people a placebo. So new drugs are generally compared not to a placebo, but to the highest standard of care. Additionally, sometimes randomization itself is unethical. This is one of the reasons why so many drugs are off-limit to pregnant people. The ethical dilemmas of doing randomized safety trials on pregnant people means such trials simply don't exist. We therefore only know the safety profiles on pregnant people if it has historically been given to those populations, or the risk of not having it is great enough, and the drug is presumed safe enough that it becomes necessary to do the trial. For example, in diabetes medication, where they actually need to treat those women. There are also some cases where the sham treatment is quite difficult to do without the people knowing, and therefore a double-blind experiment is nearly impossible. Pills are easy, but not all interventions are pills. Sometimes there's surgery or other things that cannot be controlled for with a placebo pill. These are incredibly tricky, but they do have ways of doing them. Sometimes small incisions are made for surgery interventions so that the people don't know if they actually had a real surgery or not. For good acupuncture trials, they'll stab points that supposedly aren't active. Even in drug trials, this can be tricky if the drug has strong effects that the patient will either notice or notice the absence of. A placebo-controlled randomized double-blind trial is the gold standard, but it doesn't mean that we can't know things if not all of these is present. A huge tactic of pseudoscience is to demand such in impossible situations in order to claim that we can't know anything, which is crazy talk. Of course we can know things through observational studies. It's just trickier, and we have to be more careful about how the data is analyzed. It's also more likely to need more than one study to be entirely trustworthy. This is one of the anti-vaxxers' favorite tactics. We're not going to do a placebo-controlled double-blind vaccination challenge trial on kids. It would be horrifically unethical. But we absolutely have observational studies, both in terms of historical changes and as groups of non-vaccinated children are appearing across the country, and then using those groups to look at. Remember that in this class, we're teaching you how to critically analyze science. But it's important to know that even when things aren't perfect, we can learn so much. Experiments are never perfect, but that doesn't mean that they aren't incredibly useful and that we can't get good data and information from them. For our next activity of the day, please look at each excerpt on the activity sheet and talk through the experimental design. Don't worry about trying to necessarily say this is a good experiment or a bad experiment. Just talk through what flaws may be present and what is done well. I made simplified, shortened versions with the names changed up of very standard experiments and issues that come across in the health science literature. Many of these we're going to get into the real-life expanded version at some point as the class progresses. And that'll end our discussion on this topic for the day.